Last week, we did go through basic pathophysiology and introduction to ventilation, along with the previous webinar on modes of ventilation by Murli. With that basis, I think we are tuned to increase our knowledge on the use of pulmonary graphics. Okay, ventilators have evolved over the period of time, and modern ventilators pulmonary graphics is available, and it is a very useful tool for us in troubleshooting and to ensure that the ventilation is proper. So over to Dr. Manoj to crack us the code on pulmonary graphics. Thank you.
Well, good evening, friends. Welcome to today's session. As Murali had initially said, we have gone through halfway through the basics. Now we are come to a stage where now we have ventilated the baby, and we are now monitoring the baby and trying to sail through the journey when to extubate the baby. So today's session is going to be on pulmonary graphics. Just to have a overview, we started by saying that all neonatal lungs are not equal. Lung characteristics decide on the respiratory support that the baby require, and we talked a little bit about the compliance, resistance, time constant, and all the and based on these we decide the ventilator settings, and we will define what is the problem that the baby is being ventilated for. Is it an oxygenation problem, or is it a ventilation problem? And oxygenation problem reasons can lie outside the lung as well. But inside the lung, if you want to control oxygenation, FiO2 and MAP are your key buttons, and MAP depends on, we said, PIP, PEEP, inspirate time and flow. Ventilation is purely a lung affair, so the gold standard would be the minute ventilation, because alveolar ventilation is what you want to target. Alveolar ventilation you cannot measure, so you add up dead space ventilation to alveolar ventilation and you get minute ventilation, and you aim the figure of 200 to 300 ml per kg of minute ventilation, then you will have perfect CO2 removal. And this is actually minute ventilation. We all know the formula is tidal volume into respiratory rate. We also learned that the four modes of ventilation for neonate, in a neonate are IMV or the CMV, then the SIMV, then the assist control, and the PSV. Assist control goes by the name of SIPPV, patient PTV, and all in various ventilators. And we also said that the best mode is the one that you know best. That is the one you should use. However, if you have the expertise, probably the two new modern day neonatologies, the two modes that you should be using are only assist control and PSV. We also talked about gentle ventilation, the concept of gentle ventilation where you target pH and not PCO2. PCO2 allow that your target is somewhere between 45 and 55 if it is an arterial blood gas, and pH you target when you ventilate is between 7.25 and 7.35 and nothing more than that, because the idea is the lesser number of days you want a baby to be on ventilator. If you target higher pH, we will eventually end up ventilating for a larger number of days. And we also said that supportive care is as important as ventilation when you ventilate a unit, and four pillars of support are nutrition, and then caffeine and surfactant for preterm babies, and of course the developmentally supportive care, which includes all the aspects like, suppose you are in a non-invasive ventilation, it includes your KMC, the use of breast milk, DBF, and so on and so forth. So all these are important if you want to get the benefit. And to top it all, now we know that in 21st century, ventilation should always be volume targeted. We should aim for that, because we now have enough evidence to say that there is significant improvement in short-term outcomes during the time the baby is with you, as far as and it should be adopted as a primary mode in neonates as far as possible. We, however, don't know what is the long-term outcomes, whether it scores over the other modes. But as of now, we should be using volume targeted modes. So this is what we learned. We learned about the blood gas analysis as well. So now let us go on to monitor babies. So when you monitor babies, we need to remember that what is the aim of ventilating a baby? The moment you put in a tube, you should be thinking, now when do I take it out? Which means that extubation should be the goal of intubation. Why? Because you do not want VILI, ventilation induced lung injury. And ventilation induced lung injury is what we want to really avoid at all points. If you use excess volume, that is, if you do not target volume and volume overshoots, you get volutrauma, the worst. And the other bad, on the other aspect, if you do not use adequate PEEP, you get atelectrotrauma. So these two are the ones that you are really worried about. There are other traumas as well. The pressure excess, the flow excess, the barotrauma, then the flow excess, the rheotrauma, then of course each and every breath that you give, even one cycle of breath that you give is going to trigger a cascade of cytokine which is going to have a lot of inflammatory potential as far as the alveoli are concerned. So you are going to damage the lung with every ventilation breath that you give. That's why I said we should be, the moment you put in the tube, your target should be to extubate. And this is all because we also said that because of ventilation, no baby should come to a worse state after baby is extubated. So having said all these, now let's see how are you going to monitor a baby. You put the baby on ventilator, you want to extubate the baby, but baby is not at stable. So you need to monitor. How do you monitor a baby? The best is clinical profile. You look at the vital parameter, the 5 vital parameters of the baby. You look at the hemodynamic profile of the baby. See what are you ventilating for, and are you achieving your target? Have you corrected the cause? All these will tell you whether clinical profile is improving or not. But you have the standard, gold standard of ventilation, arterial blood gas, which we discussed last Saturday. And you also take x-rays, and these days we don't take x-ray, we do ultrasound lung. So these two parameters, arterial blood gas and x-rays traditionally, but even ultrasound will tell you how you are faring as well as the baby's ventilation status is concerned. There is one more parameter which we are going to talk today, that is your pulmonary graphics. And why do you want to talk about it? Because in real time, you can do only pulmonary graphic monitoring. And of course, clinical profile, that is there always. The clinical profile of the baby takes precedence over all the other parameters. You can't do blood gas 24 hours. You can't do x-rays 24 hours. So probably the best way is to get a trend in your pulmonary graphics and then follow thereafter. What is pulmonary graphics? Well, let us go back to the first session where we define ventilation as delivery of flow to result in a pressure, because we are using pressure control ventilation, delivery of flow and pressure to the patient's airway to effect a change in the lung volume. So if this definition is valid, then you have 3 parameters that tell you how far your ventilation is going: the flow of gas, and the pressure that it results, and the volume that it creates. And pulmonary graphics is nothing but a graphical representation of pressure, flow, and volume. Now, before we start today's lecture, can I ask you all, do you use pulmonary graphics in the day-to-day management of ventilated neonates? Let's have this poll. Okay. So as predicted, most of the people use it most of the time, and some are yet to start, because I believe there are the postgraduates also in this group, and then there are quite a few learned teachers in this group. They use all the time, so that's great to know. So now, to define pulmonary graphics, you have basic parameters that you plot by plotting the pressure waveforms, the flow waveforms, and the volume waveforms. So these are your basic parameters. They are the scalars or the waveforms that you study. But you can derive. So how do you do this? All these are like you plot the pressure against time. So all these are plotted two-dimensionally against a time, and anything that you plot again in two dimension is a scalar. So these are scalars. So now, if you want to plot pressure versus flow, or pressure versus volume, flow versus volume, you get loops. So there are deduced parameters. So pulmonary graphics essentially consists of basic parameters, the waveforms, pressure, flow, volume waveforms, and the deduced parameters, the pressure volume loop, which we will be talking about a lot, then the flow volume loop. We will not be talking much about the flow pressure loop for lack of time. This is the introductory class. Now, how do we get these values? Because in medicine, the first lesson that we all learn is that to ask questions. When somebody tells you it is this, the first thing you ask is why? Or in modern day, we ask what is the evidence? So, how does the machine produce these funny or rather the elegant graphs? So, it is done by this sensor, flow sensor, the soul of a ventilator. These days we use flow sensing. If you remember the earlier classes, the various ways to trigger a breath we discussed, and we said flow sensing is the best way. So in the flow sensor, you have two electric wires which are heated and kept. And when gas flows through this, gas will cool these wires. So then a particular amount of electricity is spent to reheat the wire to the preset temperature, and this is amplified and then processed in a very sophisticated microprocessor, and you get some values, how much of energy is being used to process it. So basically the flow, the pressure, and the volume are calculated from this, and then you deduce the all other parameters, the flow volume loop, pressure volume loop, all these you deduce from this. This is how it is done. So if this is the how why it is done, then you should actually know why do you want to do it. Because as I said, clinical profile is what we always go by. We cannot do blood gas all the time, so it's good to have an ancillary, something to aid you when you look at the clinical profile of the baby, and that's where the pulmonary graphics comes in, and it's a real-time monitoring that you get. And have we all ventilated without pulmonary graphics? Yes, in the last century when we were ventilating in the late 90s, and most of us were not very familiar or using pulmonary, frequently the pulmonary graphics. You can do it, and we were doing a reasonably okay job compared to the standards at that time. But then now we have a better tool which will refine your ventilation and make it from good to an informed judgment, and we actually come to know what is happening to the lungs. So the physiology you can understand. I said we should understand, the first thing that we said when we started the lecture series was you should know the lung physiology to decide what is the type of ventilator and what is the setting that you're going to use. So if you want to know the lung physiology, this is a good tool, especially if you follow the trend. And so there is another use for pulmonary graphics is highly underutilized, especially if you, for the postgraduates in this session. Start some research. It's a great research tool which is highly underutilized. Only legends like Martin Kessler do research on this. Probably if you just look at review the literature, the original research on pulmonary graphics is not much. So it's a good research tool. Also, when we use this, we should know what are the limitations, because there can be some problem. You should know the machine that you're using, because I showed you a sophisticated process of pressure anemometer, which is going to sense the flow, and then the cooling of the gas is going to be the amount of electricity to reheat is converted. All these are technical issues, and then like always technology can fail us at any point of time. So technical problems in capturing data should be kept into your consideration when you interpret these graphics. And then of course the algorithms have their own limitations, so you should be aware of the limitations. And from each patient to each patient, the graph may look differently because all lungs are not same. And within the patient also, with different lung condition, the graphics may be different. So again, this intra and inter-patient variability is always there for pulmonary graphics. And of course, it is like any other tool. The interpretation is done by the brain, so the experience of the physician. So stethoscope hears only what is there in between the two earpiece. The same phenomenon is here, so experience of the physician holds good. And this you can attach pulmonary graphics to any of the ventilators. This is an expensive procedure. The newer modern ventilators do come with an attached pulmonary graphic pattern, but then it doesn't it need not be there. It's an expensive affair. And always remember, what you see in the pulmonary graphics will represent only the lung, which means do not correlate with your oxygenation. Or you can correlate with your ventilation, but not with your oxygenation. Oxygenation, I said, only partly is taken care of by the lung. You have the oxygen carrying capacity of the blood that gets affected. You have the cardiac contractility. You have the blood volume. You have the tissue perfusion. All these are going to affect your oxygenation. So it only represents the lung or the ventilation. Now, to interpret, before we start on the graphics, there are few more clues. You need to know your machine well. Each machine gives you slightly different pattern. Those of us who are using it will know this. And then cardiologists were the first people to use pattern recognition for diagnosis in the ECGs. Late 60s I am talking about, or even earlier than that, 1960s. So there are specific patterns which we are going to learn today, which is going to help us in really letting us know that, okay, this is going to be this. So pattern recognition is important. And we said there are two groups of pulmonary graphics, the waveforms and the loops. So whatever you see in waveforms, you have to see whether in loops, whether it is actually holding good or not. And of course, baby is supreme. So if baby doesn't, baby's condition doesn't correlate with the graphics, throw out the graphics, you respect the baby's condition. Clinical correlation is always to be done. So now let's get on to the various waveforms. This is going to be a monotonous lecture. I try to make it as interesting as possible with some polls and all. Feel free to ask questions, and then we can have hopefully we'll have some discussion at the end. So the waveforms, I said there are three types of waveform: the pressure waveform, the flow waveforms, and the volume waveforms. First, we'll talk about the pressure waveforms. When we define ventilation, I said when the flow is what determines everything, and it's a pressure limited ventilation. So when the piston valve closes, flow of gas goes into the lung, and the pressure, positive pressure, starts building. And when the valve opens, this pressure falls to a particular level, and then it remains at that pressure. So the maximum pressure that the ventilator delivers is a peak inspiratory pressure, which is represented here in your pressure. This is your pressure waveform, so it is represented here, and the minimum pressure that is remaining at the end, representing your FRC, if you remember the first class, is this, the positive and expiratory pressure, PEEP. The difference between these can be functionally called as delta P. And the time that the piston valve is closed, from the time it's closed to till the time it opens, that is a inspiratory time. And from the time the pressure valve opens, piston valve opens, till the time it closes again is a expiratory time. Further, if you are going to plot this like this, so the piston valve was opened, so the pressure has started developing, piston valve was closed, piston valve was closed, pressure started developing, piston valve is opened, and now it has fallen. So when you plot this, this is a PEEP and this PEEP pressure and this 0. So if you are going to take look at this area from one occurrence of valve closure to the next occurrence of valve closure, this much shaded area represents a mean airway pressure. So what can we learn from this? Pressure waveform is the least useful waveform, I should say, even though we study it first. Probably it is the most useful waveform for the biomedical technician, because it is going to tell you the integrity of the circuit and the ventilator. So when the ventilation, when you have a problem with the ventilator, the biomedical technician comes and he just looks at the pressure waveform. If pressure waveform is okay, then he knows that he has not much of work to do. It is a problem. You have work to do. The problem is from the ventilator till the patient, something may be wrong. So it tells you the integrity and of the circuit and the ventilator. It also tells us, as we discussed, two things: the MAP, mean airway pressure, and also it tells us the effect and adequacy of flow. These are the two things you should be remembering. I try to make everything simple by numbering. These are things you will be remembering today. So you will, the first thing is mean airway pressure. We said mean airway pressure is the area under the curve. So you can increase the mean airway pressure by increasing the PIP or increasing the PEEP, or you can increase the flow, or you can increase the inspirated time, or you can reduce the expirated time indirectly. So these are the measures that you would do to increase the mean airway pressure. And so this can be well depicted in this. But there is another parameter, another usefulness of this, that is to tell us the flow. If the flow is less, you get a curve, pressure waveform like this. So this is called a sine wave, and when you give more flow, it will turn into a square wave. So if you look at this is a square waveform, and this is a sine waveform. Both are the same PIP and PEEP. PIP is 20/5 in both, but the mean airway pressure is different in both. So this is again one way to know. So the adequacy of flow can be known. When the flow is less, you get a typical pattern. This is the flow starvation pattern that you get in pressure waveform. Now, let's have another poll. So you understood the piston valve closes and the pressure starts building up, and when the piston valve opens, the pressure falls. So you get a curve. So it is always a positive deflection that you get in a mechanical ventilator. It is a negative deflection. Later on, I'll just briefly tell you in a baby's breath. So what does this stand for? This one, can you identify this mode of ventilation? Your choices are IMV, SIMV, assist control, PSV, the 4 modes. Oh no, I had given the clue here itself. It's a time cycle pressure limited ventilation, and cycling happens by time always in all these 3 modes: IMV, SIMV and assist control. Only in PSV, it's a flow cycle pressure limited ventilation. So I given the clue. TC, PLV I written here. You should have caught the clue. Anyway, some of us have made it correct also. So pressure waveform can tell you what is the mode of ventilation as well. Okay, now let's talk about flow waveform. Flow waveform, we all know when the piston valve closes, the flow starts building up, and then once the peak inspiratory pressure is reached, the flow stops at that point. But the piston valve is not open, so flow will remain at that, and flow will start falling also, but it will never fall below 0 until the piston valve opens. Once the piston valve, so this is the time of inspiration. So this is your inspiratory time, and once the piston valve opens, you have a expiratory flow. It's a negative flow, and this will happen. The flow ceases, and then the ventilator, we wait for the next time the piston valve to close. So this is a typical flow waveform, and The flow waveform is always identified by its biphasic nature. We already saw that pressure waveform and volume waveform are only positive, have only positive deflection, but this has a negative deflection as well. Now, this is an area I am really worried about, because here what is happening, the lung is getting inflated here and lung will finish getting inflated. So this is your lung inflation time. It's called LI or lung inflation time. Similarly, this is the time of lung exhalation time. So this is actually a waste of work or a waste of time. If you find like this, you can probably increase the rate and get more if you are ventilating not enough. Anyway, we'll come to clinical scenario separately. So what can we learn from a flow waveform? You can learn various things. I just given the gist of 6 important things. It can set optimum trigger. It can optimize your inspiratory time. It can know that the airway resistance is good or bad. It can know when the airway is getting obstructed with secretions. It can tell us whether there is evidence of gas trapping, and then it can also tell us there is evidence of leak. So let's see all these one by one. How to set the optimum trigger? So suppose this is an SLE screenshot. You have set your trigger, flow trigger here, and you find that most of the flows are not getting supported because most of the baby's efforts are not getting supported. So what do you do? If you see a pattern like this, you know the trigger has to be lowered it and then further lowered it. When it reaches this level, you know that all the efforts of the baby are getting supported. So the flow waveform is going to tell you how to optimize your trigger. Now let me ask you again, can we have another poll? Which of these flow waveforms is good? Look at A, B. Look only at the flow waveform. This is a pressure waveform just to tell you how the ventilator is functioning at that point. So the A, B, C, D. Which of these flow waveforms is good? Okay. Anyway, it's interesting. Let's analyze this. I said that flow waveform can help us in optimizing the inspiratory time as well. So let's look at each of these. What is wrong with A? This is what I showed you initially. This is the lung inflation time. The flow is happening, flow is over, but the valve is not at open. So there is a time. This is a time baby will hold breath. Like this, it will hold. And that is going to increase your work of breathing. You don't want this. You don't want this extra time. Lung inflation time ideally should be equal to the inspiratory time. So this problem with this is it has a long IT. And when you have a long I time, what are the options that you have? You can either reduce the inspiratory time or you can use pressure support mode, which is actually a flow terminated breath. We discussed this. I am not going to discuss this further. So this baby was at that point converted to PSV. So what has happened here, you are finding after each flow there is a gap, whereas the moment you convert after the inspiratory flow is over, so when the flow is over, the machine will automate the valve flows. It's a flow cycling. The cycling happens and then there is a expiratory flow. So this is the most comfortable form of breath ideally for the baby. We know that there are problems with the PSV we discussed in the second module, but then theoretically this is the most ideal mode. And you can set your flow terminated sensitivity at various percentages. This was also discussed. Now, what is the problem with C? Here the inspiratory flow is perfect, but look at the expiratory flow. Expiratory flow has not touched zero. Before that, the valve is closed and the baby is made to again inhale, which means that the exhalation is not complete, and you are going to develop air trapping or auto PEEP in this scenario, because what is actually happening, you are not given sufficient time for expiratory flow to get over. What about here, D? Here it is exactly opposite to A. What has happened is that here the inspiratory flow is not over before that the valve was opened. So you are not allowed all the flow to get completed, and so this is a short IT, and this is going to cause desaturations to the baby because you are not giving enough flow, and unnecessarily your ventilator settings will go up, whereas the actual answer in such a desaturation would be increasing the I time. If you are using SIMV or SIPPV, you should be increasing the I time, not increasing the pressures. I hope this is clear. The figure is self-explanatory. You would like the lung inflation time and inspirate time to be exactly same. So the answer to our poll was B, where we had perfect, or rather perfect timing after inspiration before the expiration began, and then after that, depending on the baby's breath or whatever the reason, you wait for the next time for the piston valve to close. Okay, the next poll, what is the problem in this flow waveform? Just for those curious about this waveform, this is a square waveform, so you know that this is not from a neonate, this is from a different neonate. But what is the problem in this flow waveform? Is it increased resistance, air trapping, inappropriate trigger, or leak? Great. So that means the concept of air trapping is very, very clear, and this is what I was explaining previously. This is the auto PEEP. Now, we can also know the resistance pattern in flow waveform. If the resistance is less, the expiratory flow is complete very fast, whereas if the resistance is always there for the passive active process, you don't find much resistance unless, of course, the block is too much, the resistance is not much. And a conventional ventilation, we said, is always active in the inspiratory phase only, unlike high frequency where it's active in both the phases. So expiration is a passive process, and so here if the resistance is too much, you are going to have a long expiratory flow. So that is diagnostic of some problem. The resistance is increased here actually. So to summarize the flow waveform, you can use it to optimize your trigger, you can optimize the inspirated time, you can know when baby desaturating and then optimize your inspirated time, you can look at the airway resistance, you can look at the airway obstruction, you can detect gas trapping, auto PEEP, and you can also detect leak. So everything is possible with flow waveform. So very good. So if you understand flow concept in ventilation, probably the conventional ventilation, you know more than half of the concepts. We come to the last in the waveforms, that is the volume waveform. Now volume waveform is very simple. You have an inspiratory volume, and once the peak is your inspiratory tidal volume, and then expiration. So this is the tidal volume that you are getting with the time. So that is a simple volume waveform, and it has limited utility. It will tell you whether there is a leak or there is an accidental extubation, or more importantly, the tidal volume that you set is being delivered. Especially if you are not targeting tidal volume, then this you should be always looking at the volume waveform. It will tell you the adequacy of tidal whether it is a spontaneous breath or machine delivered. Also you will know, especially in SIMV, if all breaths are not supported. May again reiterate this point, it is not a good idea to make the baby work against a high resistance system. So that is what I have grossly against this mode of SIMV, because you are going to make the baby breathe through a straw, which is highly unphysiological. It is going to increase your total ventilation hours. This is the pattern in air leak. So you have the expiratory volume not reaching baseline. Before that, another volume starts. So the machine will join it with a line. So this is a typical pattern that you get in a leak. When there is a leak, you get this pattern. And when there is total leak or extubation, when the tube is in the esophagus, you find only inspiratory volume, you don't find the expiratory volume. Now let's talk about loops. The first loop that we'll discuss is the pressure volume loop. It's otherwise called compliance loop, because we know that the ratio of pressure and volume, or rather the delta V by delta P, we said is the compliance of the baby. So pressure volume loop is going to tell you the compliance. Sorry. Now, if you follow, this is the inspiration that is happening. The pressure that is developed, the increase in pressure is resulting in a volume change. It reaches a level, and then gradually where the valve opens, and then there is a expression that is taking place. So this is a compliance loop. This loop, if you draw a line through the middle of this, that is the slope of the curve of compliance. This is the inspiratory limb, this is the expiratory limb, and there are 2 points here. This is the lower inflection point, and this is the upper inflection point. If you understand the shape, you will know this. The importance of this I will come to. So if you are going to measure the compliance, you are going to find one line like this, and then line like this, and so this is going to be the shape, something like a shape of a penguin, if you imagine. And so this line is going to tell you the ideal compliance or the static compliance, which you cannot probably measure. You can only measure the dynamic compliance of the baby, and usually the machines will overestimate the compliance, because the pressure contributed by the baby also will get added on to the equation delta V by delta P. So now we want to ventilate between the lower inflection point and upper inflection point, which means that this is the area where we want to target. We don't want lower pressures and we don't want higher volumes. So this is the area where we want to ventilate, and this is a safe zone. If you ventilate in this area, you are going to cause more collapse of lung, so you're going to get atelectrotrauma. And if you are going to ventilate in this area with more volume, you are not going to, with more increase in pressure, actually you are not increasing the volume much, and unnecessarily you will land up with barotrauma and volutrauma. So now, what can we learn from the pressure volume loop? You have a loop that is going to tell you the compliance of the lung. So the very, very important loop. It can tell you how the compliance of the compliance of the lung of the baby changes with time. So changing compliance, and then it can also tell us the evidence. It can show us the evidence of air trapping, overdistension. It can show us the leak, the inadequacy of the flow, or if there is flow starvation, then if there is optimum, if the opening pressure is optimum or not, and when secretions come in the way and then resistance increase. All these we can learn from pressure volume loop. So if you imagine the hysteresis or the pressure volume loop to be a penguin, penguin is sleeping when the compliance is low, and penguin is standing when the compliance is high. So flat loop, low compliance, because actually the compliance, why is it low? Because higher pressures is resulting in only lower volume. Whereas when the loop is upright, lower pressures are resulting in higher volume. So this is depicted here. Now, 3 compliance of the same lung are shown. So the middle one with the 45 degrees is the normal one. Probably this is when the baby was, if it was a preterm during RDS, and this is after surfactant. And if you ventilate, after some time we say that the lung become hyper compliant, and then you develop BPD. So the penguin will stand more and more if the compliance increases. This is just a demo of the same thing. Anyway, the video is not working, so so this is the sleeping penguin, the compliance loop in severe RDS, and then once you given surfactant, you get a nice football shape with the 45 degrees angle. So this is this is one of the loops that is going to tell us the compliance. Now compliance loop can also tell you whether you are doing more. I told you this is the ideal area to ventilate, the upper inflection point and lower inflection point. Between that, if you are going to give more and more pressure, this pressure, suppose you have set up fixed pressure, you are going to this pressure is going to be more and more, so this is going to create some problem. So you get a typical pattern. This is the Beaking pattern that is seen in overdistension, which you can avoid if you target volume here instead of targeting pressure. So this overdistension, Murali had actually alluded to the C20 by C ratio. What is the C20 by C ratio? The compliance in this last 20% of the compliance loop as a ratio to the total compliance. It should, ideally it should be 1. If you are ventilating, you are using volume targeter, but at least it should be more than 0.8. If it is less than 0.8, the C20 by C ratio is more than 0.8, you are using too much pressure, you are over-distant in the lung, you need to come down. And most of the modern day ventilators will tell you the C20 by C ratio in its measured panel. So now let's have the next poll. What is the problem here? Is it increased resistance, leak, flow starvation, or air trapping? It's a slightly tricky one. If you follow the basics, you get it. Okay, narrow majority. So this is probably a flow starvation tracing, and little more flow you give. Again, I'm sorry, the videos are not working. So you little more pressure, and you will find that the figure of 8 will turn into a proper compliance loop. The next use of a compliance loop or pressure volume loop is to know the leak. In leak, what happens? You have the inspiratory limb complete, but the expiratory limb, because of leak, the last part is not there. So the machine will join with a straight line. You will find a straight line, unnatural artificial line. That is the modern day ventilator joining. So this is your leak. Now, flow volume, pressure volume loop can also tell us if the resistance is increasing, if secretions are increasing and resistance is increasing, the width of the compliance loop increases, and you will find that there is some beaking also happening. So increasing inspiratory resistance will result in increasing width here, and increasing expiratory resistance will result in increasing width here. Usually you find this one increasing because of secretions. This is more of a specific problem, like the tube getting blocked or something, because and the pressure is not delivered or something like that. Pressure volume loop can also tell you what is the ideal PEEP to use. You know that in this is an inadequate PEEP. You should be using this as a PEEP and not this value. This pressure should not be. This is 3 or 4 and this is 6. So probably you should be starting with 6 here to get the best loop. So optimum opening pressure can be inferred from a ventilator using a compliance loop. So to summarize, the pressure volume loop will tell us the changing compliance, the air trapping or overdistension, the leak, whether there is flow starvation, the opening pressure is optimized or not, or PEEP is adequate or not, and if there is increasing resistance in the airway. Now, before we go on to the next one, I want to impress upon this point upon all of you. We don't live in a perfect world, and all alveoli are not equal. The compliance of some of the well-distant alveoli are different from the other alveoli, and most of the disease conditions are heterogeneous lung diseases like pneumonia and things like that. So if you have a heterogeneous lung disease, it's a challenging task to ventilate. On one hand, you are you may be hyperventilating some of the alveoli, and on the other hand, you may be ventilating the you are causing atelectroma. So idea is to remain in this zone. It's a challenging task, so that is where you need to these graphs come in handy. This the graph is going to tell you the total overall compliance of the lung, and then you need to deduce depending on the disease condition whether majority fall in this or not. Please remember this when you ventilate babies. Let's now go on to the last loop which we'll discuss. We will not discuss flow pressure loop. So flow volume loop. Flow volume loop is relatively simple. You plot flow against volume. So you have a peak inspiratory flow rate at this point. This is the inspiratory phase and this is the expiratory phase. And the this point where you start off is a functional residual capacity, and this point is your tidal volume. So you from here you are going to give so much of pressure, so much of volume. So tidal volume from PEEP. So if your PEEP is inadequate, then probably you can detect from here as well. So the three things which you should remember to learn detect from flow volume loop are different resistance patterns, the air trapping and air leak. Resistance pattern comes in many ways. Usually I said resistance pattern first comes in the expiratory limb, and you get the typical scooped out pattern, or you may find this pattern, and when there is a resistance all over, you find a rug pattern like this all over in the inspiratory and expiratory limb. And this is the typical pattern then you get when your expiratory flow does not reach 0. So it ends here. So you get a auto PEEP or air trapping. So this graph, the inspiratory limb is perfect, the expiratory limb will come something like this, and then machine will join it like this. So this is here for air trapping or auto PEEP. In leak, what is going to happen is that expiratory volume is not complete, we said, so it is going to end here. The expiratory volume will end here. So this is the typical pattern that you get in leak. So that is it. You have learned almost everything in the basic concepts in pulmonary graphics. So let's now identify 2-3 problems. What is the problem here? When I say identify a problem, you always need to look at both at least one waveform and one loop. That's why I shown two. What is it? A leak, a tube block, a flow starvation, or increasing resistance. Excellent. So that means you have understood the concept, or you already knew before you attended this thing. So this is a typical leak. Okay, great. Now let's have a scenario, clinical scenario. A very preterm infant, 1 kg baby, ventilated on assist control mode, 18/4, inspirate time of 0.37, tidal volume now recording 1 ml. The original reason for ventilating, usually very preterm babies we don't ventilate much. Extreme preterm babies are the ones who land upon ventilator. So very preterm baby means from 28 weeks to 32 weeks, 31 weeks complete. So here the ventilation was for pneumonia, and baby was initially doing well. Then suddenly you got a call and you see that baby is desaturating. You looked at the pulmonary graphics and this is what you find. What is the problem here? Is it a leak? Is it a ventilator failure? Is it flow starvation? Or is it ET tube blocked? Okay, great. 50% have got it right. So this is a scenario. What is actually happening here? Sorry. You have first when you're called with such a problem, what is it that you do? First, you look at the pressure waveform. pressure waveform is delivering correctly, so that means you have half your problem is over. Now you look at the flow. Is the flow being delivered? No. And is the tidal volume being delivered? No. So probably there is a problem after the tube. So from the choices, the most likely it is ET tube blocked, and probably this baby improved on suction. Same baby, suppose this was the picture. What is the problem? That is your next poll. Is it leak, or is it ventilator failure, or is it flow starvation, or it blocked? Great. So I think that means we have really understood the concept very well. Here your pressure waveform is not correct, so then you don't no need to look anything. If your pressure is not delivered, then the flow waveform and volume waveform will not be correct. So we know that this is a scenario where you cannot expect that anything is wrong here, unless of course you rectify the ventilator. So so same algorithm of doping equipment failure, probably that is what is wrong here. So I think I've tried to cover almost all the aspects, keeping some time purposefully for the discussion part. So before I wind up, let me again stress on this point. When you ventilate babies, please do not do any harm. In 1980s and 90s, when we started ventilating, at least when I started ventilating, uh, always we used to target a PCO2 of say 35 to 45, and pH was 7.35 to 7.45, and eventually babies used to have problems like brain injury. Then we realized that we should not take control, let the baby take control, and if the baby is going to take control, you need to let go do the minimum. And so you use more baby friendly modes, and then you use it in such a way that you just give maximum guidance but let the baby do its own work. So aim for PSV. Most of the time PSV mode will not work, so go for the next best assist control, because probably until the baby's brain is okay and baby does not have physiologic tachypnea and all, PSV mode may not be a good option. So uh, when whatever mode you use, you should know the lung physiology, and you should always make sure that you combine all the four parameters I mentioned when you ventilate. The moment you put in a tube, your goal should be to extubate, and for that the fourth thing that you would look at is the clinical condition of the baby and pulmonary graphics all the time. And of course, in between, if you do this, then the number of blood gases that you do, you will be surprised to find the number will go down, and then X-ray very rarely. So that is how you monitor a baby. So the weaning strategies have also been discussed so far. So I think you are good to go as far as the initial part is concerned. Now we will have some discussion now, and then probably in tomorrow's at the end of tomorrow's session, we would take your opinion about further how the second module and all that. So thank you. So now may I request the moderator to take over.
That was an excellent talk, Manoj, and it was such a difficult topic which you have started to explain so lucidly, and I'm sure there'll be a lot of questions. We already have many in the chat box. The first question is, do you normally use compliance loop, pre and post surfactant?
I always look at the loops. For surfactant, no, because most of the time these days, what is happening is you don't give surfactant, and at that time, most of the time, baby is not on ventilator. You are either insuring or you are doing LISA to give surfactant. So you don't really have the ventilation loops for the non-invasive modes. But suppose it happens that I don't think in the recent this thing we have looked at the compliance loop to know the efficacy of surfactant. Compliance loop is looked at in ventilated babies. When you, of course, the moment you put the baby on ventilator, the two things that I would always look are the flow volume, flow waveform, and the compliance loop. And rest is all secondary for me. But that's again a personal choice. All the waveforms and all the loops are important. And compliance loop is going to give you a lot of information, because you are going to see the loop. If you can always, in some of the ventilators, you have facility to capture the loop and keep, and you can compare, or you can take screenshots. So every day or every 6 hours, you take the loop and see. Problem is, you should interpret correctly. You should know how to interpret the artifacts, because the baby is on breath triggering. So it depends on interpretation. Slightly dicey when you're using more advanced mods, but then probably that's the way it is. So the answer is, for surfactant use as a routine practice, I don't look at compliance loop. Most of the time,
Probably, yeah, when you want to give the second dose of surfactant, you might.
how many times do you give second dose of surfactant? Very, very rare. So probably at that point, yes. And there are other ways to monitor the surfactant requirement and or other things. Compliance loop is being looked at as in all ventilated babies to know what is happening to a lung. Because initially itself, I use volume targeting. So you are looking at the compliance loop to know whether is it time to wean further. So probably you should look at it all the time. I hope I have made myself clear.
Somebody wants to know about explain flow starvation again. Flow starvation.
Flow starvation is a concept where actually you need to give, because we are using flow as the primary driving force to work a ventilator. We use pressure limited ventilation, but then if the flow is not there, the pressure is not going to be generated. Flow happens first, then the pressure is generated, and this pressure creates a volume. Do not confuse this with the graphics which have to be interpreted in a slightly different way. So when there is no adequate flow, you will find that the typical pattern I showed you in the pressure waveform and also in the compliance loop. Both the figure of 8 pattern in the compliance loop is almost always diagnostic, of course, unless you don't take care of artifacts. If you take care of artifact, flow waveform is very well done. And this is required for slightly advanced methods or for the very old methods, because normally in the modern day ventilators you don't adjust flow, except of course in VN500 you have a provision. So that's why it's a very advanced mode also. Otherwise in the most of the other ventilators, ventilator adjusts the flow, but you have a provision to adjust. In SLE, what you do is that you change the waveform, and that is how you adjust the flow. Whereas in dragger, you directly take control of the flow. So you can adjust the flow if you find that the typical pattern is there. Because if you don't give sufficient flow, what is going to happen? Your ventilator settings are going to go up, and unknowingly you will realize this, that ventilator settings are high. Why? Because your flow is not adequate, not because of anything else. You are not given adequate flow. Most of the time, flow should be used, minimum flow should be used to prevent rheotrauma, which we just alluded to. Those things are being talked in advanced graphics classes, but then probably rheotrauma is something you should prevent. So flow you need to optimize. I told you how to optimize in your compliance loop.
What is the best pulmonary graphics to assess adequacy of ventilation?
Sorry, what is the question?
Best pulmonary graphics to assess adequacy of ventilation. Ideal graph.
Again, that is a very difficult question. It is like asking which is the best mod. Best pulmonary graphics means you have to best parameter. If you are, ideally, if the question is which is the best parameter to monitor, it is the clinical profile. You should know why are you ventilating a baby, and based on that, now am I doing the correct settings? That is how. So After that, only pulmonary graphics come. If you're asking which is I told you my favorite, it is not best. It is my favorite favorite are flow waveform and compliance loop, but then others also have their importance. For example, a biomedical technician, he wants pressure waveform to be looked at because that is what is going to tell him the integrity of the ventilator. So there is nothing called best. It is your. We know that now, isn't it? In neonatology, it's always there is nothing called black and white. It's always shades of.
In which scenario we have to disconnect the baby from MV, mechanical ventilation? In which scenario we have to disconnect the baby from MV,
Okay.
mechanical ventilation?
I think what is the question is when the baby is desaturating and then you want to disconnect and bag and see whether baby is improving. If is that hopefully
Most probably that.
Probably that will be the question. Probably.
That is the question. Yeah.
That is the scenario. Then probably you should understand certain basic principles of a ventilator. What is it? How is it different from bagging? If you're finding that bagging improves the baby and the ventilator baby desaturating, two things. Your delta P in bagging is very very high. Delta P is the difference between PEEP and PIP. You don't have a PEEP in bag and mass, which means that much PIP minus PEEP is a delta P. So the delta P is what is improving the baby, means you can either reduce the PEEP and C, it depends, or you can increase the PIP and C. Bagging means you are using 40 by 4 is a PIP and PEEP. So you can do it at 40 by 0. Why do you want to disconnect? Or if you have a machine that has an option of high frequency ventilation, that is the time to change over to that. There are scenarios where there may be the tube may be blocked, and I think that is why what prompted the question. So if tube is blocked, you can know it from the graphic. You don't need to disconnect. So disconnecting and losing all the FRC that you built up in ventilating is not a good idea. But probably we all learned it that way because that was the Esther years ventilation. Baby desaturating, remove from ventilator and bag. Probably we should not do that. We should try to evolve to rather understanding the concept. Bagging, whatever the pressure that you give, you can manipulate and give in the ventilator. Reduce PEEP and C, or take off the volume. If you are using volume, you switch off the volume and then increase the PIP to 30 and see whether it's increasing, or 40 and see. And so then you know that this is not in the conventional range. So you need to change to high frequency or whatever other measures, or probably you need to do a suction, or you need to look at the other causes that is causing the desaturation. I hope I'm answered that question.
Oh yeah, probably the question might have arises because if you want to know the ventilator is malfunctioning, anyhow you can disconnect and bag the baby.
Why do you want to do that? You are worried about the baby, not about the ventilator. It's a biomedical technician's job. Of course, that is there. If you want to know whether the ventilator is at fault for a short period of 10-15 seconds, you set everything, get the bag ready, and then disconnect, and then connect a sling to the ventilator and bag and see whether what is the ventilator doing. Yes, you can do that theoretically, but I don't think it's a sensible idea to do that.
How to know the poor compliance?
I told you already.
I already explained. Yeah.
Will be sleeping, which means that compliance loop is actually a pressure volume loop with the pressure in the x-axis and volume in the y-axis. So when you need more pressure to generate a smaller volume, you're actually, it's a falling graph, or penguin is sleeping. So that is your low compliance. As the compliance improves, the penguin will stand up. So the compliance, if you draw a line through the middle, it will slowly rise.
Next is an interesting question. Does the frequent changes in intrathoracic pressure in volume targeted ventilation make the baby more susceptible to develop IVH?
Yes, this is a very interesting question. I had some slides at the end. I will just share one of those slides. Let me see. Okay. So, the hemodynamic impact of mechanical ventilation is profound. The transpulmonary pressures and the lung volume changes are going to affect other parameters as well. You know that rather the lung volume is kept at adequate pressure, but when you're going to do this, the pulmonary vascular pressures and the systemic vascular pressures are going to get affected by this. If your blood pressure is low, you might have already been on inotrope at this point, and probably at this point, even a slight change, you see it is the changes are going to be more dramatic. So probably you cannot really say that ventilation is a safe procedure. Any ventilation can cause in brain injury. The small changes, because we do not have that pulmonary and the vascular protective mechanism operating in the brain. So probably any change will cause, any transpulmonary change will cause some change in the systemic pressure, and then this can create problems. But then we need to weigh the benefits and risks. If you don't ventilate, baby will die anyway. So the best way to ventilate nicely. And how do you ventilate? The two basic, and this is what I am again and again stressing, the best way to ventilate would be to target tidal volume, so that you do the minimum volutrauma. Volutrauma is the one that causes maximum notorious in this. Target tidal volume and prevent atelectative trauma, and of course gives the minimum deflections. Again, this is not totally proven by evidence. At least theoretically, hypothetically, minimum deflection. That is the advantage of using high frequency. High frequency probably scores over conventional ventilation. This anyway, this is beyond today's this thing. So probably, definitely, you're going to cause harm when you ventilate. But do you have any other go? You have to. So if you're going to cause harm, at least cause minimum harm. Don't use very cruel mods and make the baby breathe through the straw and all that.
Characteristic graphics in pneumothorax.
Pneumothorax graphics, anyway, I don't have the graphic right now. So again, it is more like if you are each and you will find the typical change in the flow or in the volume, and in the pressure volume loop also you will find the changes. You will find that part of it is totally missing, because what is the air is going in, it is not coming out. It is something like, it's not exactly something like a leak. Air is going in, air is not coming up. The inspiratory part will be okay, expiratory part you will find. Initially it will look exactly like a leak, but as the pneumothorax develops tension, then the profile will change. Probably these are discussed.
It goes to gas trapping. That's
yeah. These are discussed in the advanced concept. The basic look I have shown you I asked a question also in the poll regarding how does leak look. So something, and then the air trapping, you can take the mix of that.
I think that's the last question, Manoj.
Oh, great.
Now, that was a wonderful talk. Hey, you want to add anything, Murli?
No, nothing. Everything almost.
That is a wonderful talk. See, I started learning ventilation in the late 90s, where we ventilated with Bear Cub and Infant Star, etc. And over a period of time, it has been a learning curve for me with regards to pulmonary graphics. Yeah, and only when you start using it, you get to know more and more. So I think the lesson or for everyone is to see the graphs, okay, and that's how you learn. And fortunately, we have uploaded today's lesson in the YouTube, okay, and you can go through it again and again. As you go through it, it will become easier for everyone. Okay, thank you.
Thank you so much. May I request all of you to kindly be present tomorrow also for our last in the concluding basic series, disease specific ventilation, so that we finish this basic concepts, and then probably then we can decide whether we need to continue with the further dialogue and all that. Thank you. Thank you for hearing.
Now I invite Dr. Srijit to have the vote of thanks.
Thank you, Murli, for inviting me. And on the behalf of TNF, Thrissur Neonatal Forum, and IAP Thrissur, I thank all the participants who have joined here for the 5th day. And also I thank Manoj sir for an excellent presentation for describing the ventilator graphics in a very lucid way. And also Srini sir for moderating this session wonderfully well. And tomorrow, as sir also told, tomorrow we have another session. Like we are dealing with the disease-specific ventilation by Dr. V Francis, and all the faculty will be there in tomorrow's session. So any questions left undiscussed or any new doubts can also be dealt there. So I expect all of you to join tomorrow's session also. So all from once again, thank you for all joining us, and hope to see you tomorrow. Thank you and good night.
Thank you.
Thank you very much.